During this lecture, you will be able to understand the pathophysiology of fetal circulation, and you will be appreciating the difference between normal fetal circulation and postnatal circulation. If you know the normal, you will be able to identify the abnormal. Now, we finished the fetal heart rate baseline, and you know the normal and the abnormal fetal heart rate baseline, and we are going to shift toward the baseline variability. Fetal heart variability. Fetal heart variability is an important indicator of fetal well-being and can be categorized into short-term variability and long-term variability. What we are seeing in CDG is the long-term variability. Fetal heart rate variability is influenced by sympathetic and parasympathetic nervous system. The long-term variability is primarily regulated by sympathetic activity, which is directly influenced by the cardioregulatory and respiratory center in the brain. As we mentioned, the long-term variability is influenced by sympathetic traffic. The long-term variability considered to be normal if it's oscillated 5 to 15 beats per minute for 5 cycle duration, where the short-term variability is 2 to 5 beats per minute. What is the cause of the variability? We have to know that the long-term variability is under the influence of the sympathetic and parasympathetic nervous system, which is primarily regulated under the direct influence of both the cardioregulatory center and the respiratory center. The cardioregulatory center is located in the floor of the medulla adjacent to the respiratory center. Its function to receive input from the various sources, including the peripheral chemoreceptor, baroreceptor, volume receptor, stretch receptor, and reticuloactivating system. As we mentioned, the cardioregulatory center located in the floor of the medulla adjacent to the respiratory center, whereas the peripheral chemoreceptor located in the carotid body and the carotid artery, and these receptors are stimulated by drop in the peripheral oxygen concentration or increase in the carbon dioxide concentration, sending impulses to the carotid regulatory and respiratory center. Baroreceptor found in the aortic arch and the carotid sinus, and this receptor responds to fluctuation in blood pressure, both hypotension and hypertension. Whereas volume receptor located in the greater thoracic vein and the right atrium of the heart, and they are respond to change in the blood pressure. The stretch receptor located in the fetal lung, and this receptor responds for stretch of the lung tissue. The reticuloactivating center located in the midbrain, and it's influenced by cerebral cortex activity, the proprioceptor in the skin, joint, posterior pharynx receptor, and these central affecting the sinoatrial SA nodes in the heart, causing variation in long-term variability. The integration of input from these various receptors, ensuring the adaptive regulation of the fetal heart rate, contributing to the overall assessment of the fetal well-being during labor. Let's see how the reticular activating system in the midbrain is working. The reticular activating system in the midbrain affecting directly the cardioregulatory center through sympathetic and parasympathetic, autonomic sympathetic and autonomic parasympathetic vagus. In a fetus preterm less than 32-week gestation, the fetal baseline tachycardia will be there. That means the fetal heart rate will be around 160, not more than that. There will be increase in the long-term variability and decrease in the short-term variability. What we mean by increasing the long-term variability, it's the cycling will be more in the long-term variability. With the fetus more than 32-week gestation, the parasympathetic will grow, and this will lead to normalization of the fetal heart rate and the variability will be intact. Remember that the reticular activating system in the midbrain is influenced by the fetal movement, breathing, and all of this is affected by the sleep cycle. So the fetus getting in sleep between 30 and 40 minutes. During the sleep cycle, there will be decrease or absence in the long-term variability. There is several factors altering the long-term variability, apart from sleeping. External factors cause central nervous system depression. Drug like atropine, beta-adrenergic blocker, and the interruption of the vagal efferent traffic due to sleeping period. There is alterations of the cardiac contractions, supraventricular tachycardia or bradycardia, hypoxia itself, affecting the autonomical parasympathetic vagus and reduce the variability. When we are talking about the long and short-term variability, the people they are getting confused. Shall we look for the long-term variability or the short-term variability? The short-term variability is for the knowledge. It is a short-term variability 2 to 4 beat per 1 to 2 seconds. And you can see this is the small fluctuation, and this is small fluctuation. It is the short-term variability. The ACE node is regulated by vagal efferent fiber. Whenever there is a vagal or parasympathetic stimulation, there will be a reduce in the fetal heart rate. And whenever there is a stopping of the vagal, there will be increase in the fetal heart rate. So the several factors acting to reduce the long-term variability. Some of these factors, like external factor causing central nervous system depression, like atropine, beta-adrenergic blocker, or reducing the long-term variability. Sleep period, which is can leading to the interruptions of the vagal efferent traffic. If it's exceeding 40 minutes, that is considered to be non-reassuring. And if it's exceeding 50 minutes, it will be considered to be pathological. Alteration of the cardiac contractions, like supraventricular tachycardia or bradycardia. Hypoxia cause autonomic parasympathetic vagal stimulation. So this is a more factor which is can affecting the long term. Variability should be considered in concern. Saltatory variability. Saltatory variability defined when the long-term variability increased, which is more than 25 beats per minute. It can be due to normal causes like vulnerable cord or gross body movement, or it can be pathological due to the fetal hemorrhage and prolonged uterine contraction. Now we understand the fetal heart baseline, the baseline variability, and we are going to tackle the acceleration. So acceleration is defined as increasing the heart rate greater than 15 beats per minute for 15 seconds. To acceleration at 20 minutes is considered to be reactive tracing. So acceleration as reassuring sign as they show fetal responsiveness and the integrity of the mechanism controlling the heart. So don't consider the absence of acceleration in the intrapartum interpretation as abnormal. Why? Because the fetus is going during the uterine contraction with hypoxemic stage. And this hypoxemia will alert the fetus to reserve the blood for the vital organ. So he stop blinking, stop breathing, stop movement, and all this is the cause of acceleration. So during the labor, acceleration, absence of acceleration shouldn't be considered as ominous sign. Whereas antenatally, if there is an absence of acceleration, should be considered a non-reassuring sign and further investigation should be carried out. Other factor which can influence the variability and influence the fetal heart rate is the lived mother. If the woman is sitting, standing, or in the lateral positions, there will be enough amount of blood flow, and this is leading to the normal perfusion and normal CTG. But what happens if the woman is lying in her back? If the woman is lying in her back, this is the fetus and the uterus. The gravid uterus is going to compress the inferior vena cava, and this is lead to reduce the venous return to the maternal heart, lead to reduce the cardiac output and systematic hypotension, decrease placental perfusion, and leading to fetal tachycardia and late or variable deceleration. So how we can correct it? Just put the patient in semi-sitting position or 45-degree, or put her to the left lateral position with a pillow below her right shoulder. Will relieve the compressed inferior vena cava and is going to get the CTG back to normal. The fourth features of fetal heart rate is the presence of deceleration. Will tackle it in separate lecture. Thank you for your commitment to better obstetric care.